Medicines and the kidney. So medicines can lead to renal damage in a number of different ways, and examples are given. In the wrong circumstances, life-saving medicines can do more harm than good. Doctors, pharmacists, and nurses can help their patients by checking their treatment charts in the hospital or at the outpatients department. The medicines may cause renal impairment and must therefore be stopped or not prescribed in patients with deteriorating renal function. And all the medicines should be dosed based on the kidney function as estimated GFR, and avoid concomitant use of nephrotoxic medications and diuretics. Monitor renal function before and during treatment, and patient related risk factors for all these medications include age, pre-existing chronic kidney disease, volume depletion, and concurrent use of nephrotoxic medicines. Okay, so let's look at the medications, risk factor, pathophysiology, and prevention. There's cyclovir, high dose IV, bolus dose. That's a risk factor. And the pathophysiology, the position of the cyclovir crystals, intratubular obstruction and foci of interstitial inflammation, and also crystal nephropathy and proximal tubulopathy. So prevention: avoid bolus dose and prior hydration, maintain urine output more than 75 milliliters per hour, and slow drug infusion over 1 to 2 hours. Okay, so then next medication is aminoglycosides, for example, gentamicin. The risk factor: dose, duration, and frequency of administration, concurrent renal ischemia or administration of nephrotoxins, liver disease, plasma concentration more than 10 milligrams as per DL peak. The pathophysiology: in proximal tubal aminoglycoside bound to anionic phospholipid delivered to megalin endocytic uptake into the cell, and within cell accumulates direct toxicity, AKI, that's acute kidney injury. So prevention: maintain therapeutic range and give one's daily dose if necessary. Next is angiotensin converting enzyme inhibitors or angiotensin receptor blockers like lisinopril, as the ACE inhibitor, or losartan, that's the ARBs. So risk factor: vasoconstriction, pre-renal ARF, and pathophysiology: avoiding bilateral renal artery stenosis. Non-steroidal anti-inflammatory drugs, for example, ibuprofen. So risk factor: volume and sodium depletion, diuretic use, large dose and long therapy, severe liver disease. Pathophysiology: hemodynamically induced AKI due to vasoconstriction via reduced prostaglandin production, and acute and chronic tubulointerstitial nephritis with or without nephrotic syndrome, and direct toxicity, chronic interstitial nephritis, and papillary necrosis. Avoid co-prescription of diuretics. Avoid large doses as a prevention. So, radio contrast, risk factor: dose and frequency, osmolarity of contrast media. Pathophysiology: high osmolarity, medullary vasoconstriction, active transport intake, ascending loop of Henle, increased oxygen demand, and hydration before and after administration of acetylcysteine unproven. As for prevention, for methotrexate, The risk factor is acidic urine, as at high doses, and pathophysiology precipitates in the urine and indicates tubular injury. And prevention, so prior hydration, that's alkaline urine to a pH of more than 7, that's 3 liters of 5% dextrose in water, plus 44 to 66 millimoles of Na8CO3 per day, and sodium hydrogen carbonate per day. Okay, so cisplatin, as low chloride, high dose chlorine in cis position replaced by H2, that's water, highly reactive hydroxyl radical via CYP 450, and DNA injury, and also tubular cell death, nephrogenic diabetes insipidus, hypomagnesemia, and this may be persistent. Prevention, mesna. So medication, cyclosporin or tricolimus. So the risk factor, those age, postoperative AKI, acute kidney injury, diabetes, hypertension, those are the risk factors. And the pathophysiology, decreased GP and PG, and increased 20 HET acid production, and vasoconstriction, generation of H2O2 resulting in depletion glutathione, and decreased GFR, ischemia, ischemic collapse or scarring of the glomeruli, vacuolization of the tubules and focal areas of tubular atrophy, and intestinal fibrosis. Prevention is maintaining therapeutic range, avoid drugs that raise CYP 3A4 inhibitors and calcium channel blockers. Interferon, that's the next medication. Pathophysiology, so perirenal AKI and tubulointerstitial nephritis, thrombotic micro angiopathy, and membranous and proliferative glomerulonephritis. Tenofovir, risk factors, dose, duration, pathophysiology, tubular cell chyomegaly, so degeneration and necrosis, interstitial nephritis, AKI, and Fanconi syndrome. So next medication is lithium. Risk factors, renal impairment, dehydration, hyponatremia, diuretic use, especially diuretics, and pathophysiology, impairment of collecting duct, concentrating ability, and diabetes insipidus, chronic tubulointerstitial nephropathy. Prevention, therapeutic range 0.6 to 1.2 millimoles per liter. Prevent dehydration, avoid low sodium diets, and avoid thiazide.